Thank you all so much for joining me today. Today, we're going to be talking about ending the STI epidemic through prevention, the role of DoxyPEP. So the goals for today are just to briefly review the state of the HIV and STI epidemic, summarize the current landscape of HIV and STI prevention options, appraise new methods for STI prevention like DoxyPEP, and discuss implementation of DoxyPEP. This is just our standard PTC disclaimer. And we will start with our first poll. Where is your clinic on your DoxyPEP journey? Choose whatever answer is the closest. So are you offering DoxyPEP routinely to all patients? Are you not currently offering DoxyPEP? Or are you somewhere in between? All right, so it looks like about a quarter of patients offer DoxyPEP to all patients, about 12% don't offer it at all. About a third don't offer DoxyPEP currently, but are planning to in the future. So for those who are not yet offering DoxyPEP to those with prior STIs, at least with prior STIs in the prior 12 months, this will definitely be very helpful. For those of you who are offering it already, this will still be helpful because we'll talk about some of the nuanced and advanced management of DoxyPEP. I just always like to start with why DoxyPEP is so important. And it's because STIs are prevalent. Globally, nearly 374 million new curable STIs occur every year, which is almost a million infections every single day. In the United States, while chlamydia and gonorrhea have declined slightly, syphilis has surged 61% and congenital syphilis by 106% just over the last 5 years. In addition to being prevalent, STIs are expensive. This is actually older data now, but in 2018, STIs cost about $16 billion per year, with over $1 billion going to gonorrhea, chlamydia, and syphilis, the most common but easily treatable bacterial STIs. And since then, costs have only increased and infections have only gone up. We need to prevent sexually transmitted infections because the more cases we have, the more significant and clinically meaningful complications that we see. These numbers make clear why prevention has to be front and center. On the left, you see the male to female ratio for syphilis. It's long been thought that it disproportionately affected men, and particularly men who have sex with men, but we now see that cases among women are rising sharply. That pink line you see there is the male to female rate ratio, and the reason it's going down is that while cases are increasing in both males and females, they're increasing much more rapidly among women, leading to the declining male to female rate ratio. And on the right, this rise has translated into a tragedy. Congenital syphilis has increased more than tenfold in just a decade, with nearly 4,000 newborns affected over the past year. And so this is exactly why we can't just wait to treat infections like syphilis when we find them. We need to actively prevent them. Another complication we need to talk about is rising antibiotic resistance, particularly Neisseria gonorrhea. The World Health Organization and the CDC have both highlighted growing resistance worldwide, with increasing reports of reduced susceptibility to nearly every class of antibiotics. For more than a decade, gonorrhea has been on the CDC's list of urgent resistance threats. And this has never been more salient than over the past few years, when we've seen increases in worldwide gonorrhea resistance. And in the United States, just a couple of years ago, we saw our first 2 cases of multi-drug non-susceptible gonorrhea. These isolates had reduced susceptibility to ceftriaxone, cefixime, and azithromycin, and were resistant to Cipro, penicillin, and tetracyclines. The bigger concern, especially here in the States, is that most cases are not diagnosed via culture. They're diagnosed via NAT, or nucleic acid amplification testing. And so we don't know the true rates of resistance. What we do know is that treatment options are narrowing, which is why we need more prevention. And finally, just a reminder, STIs are not benign. The CDC often highlights how untreated infections can increase the risk of acquiring or transmitting HIV, cause long-term pelvic and abdominal pain, and lead to infertility or pregnancy complications. But the list goes beyond that. Untreated STIs can result in urethral strictures, gastrointestinal fistulas, perirectal abscesses, and the severe complications of syphilis, including permanent hearing or vision loss. So when we talk about prevention methods, it's critical to keep in mind STIs are common, but they can have very serious consequences. And that's why we need to think broadly about the STI prevention landscape and at what tools we have like DoxyPEP. So this is always how I like to start thinking about it. I like to think about the STI prevention landscape broken into primary and secondary prevention. Primary prevention is about avoiding disease entirely. Interventions that occur before infections happen. Condoms, when used consistently, are protective against multiple STIs. Risk reduction counseling helps patients think through their behaviors and adopt safer practices. Vaccination protects against Hep A, B, HPV, and now increasingly Mpox. And medication prophylaxis includes strategies like HIV PEP, HIV PrEP, and as we'll discuss a lot today, doxycycline post-exposure prophylaxis. Secondary prevention focuses on catching and treating infections early to stop further propagation of disease. This includes things like routine screenings to detect asymptomatic disease early and offer treatment. Syndromic testing and treatment to ensure patients with symptoms get rapid care. Presumptive treatment after exposure can be offered even before results return. And partner services, including expedited partner therapy, allow us to treat exposed partners, reducing the risk of reinfection of our patients. Taken together, these tools are the backbone of STI prevention. But what's most important is that the more options we have, the more we can find something that fits with a patient's lifestyle and preferences. So the next poll, which prevention method are you least likely to offer patients regularly? Barrier protection, risk reduction counseling, vaccination, medication prophylaxis, routine screening, symptomatic treatment, presumptive treatment, partner services, or expedited partner therapy? Which are you least likely to offer patients regularly? All right, and it looks like medication prophylaxis is least offered. Vaccination is up there. Presumptive treatment and then partner services and expedited partner therapy are least common. All right. So again, these are all things we can offer our patients. And partner services and expedited partner therapy, which were combined way over 50% of the answers, are great ways we have for preventing reinfection in our patients, which we know is much more common than treatment failure. All right, moving on to today's topic, we're going to focus today on medication prophylaxis. The first and longest standing example we have is HIV post-exposure prophylaxis, or HIV PEP. This involves taking a 28-day course of antiretroviral therapy after an exposure to HIV. The next thing we have is HIV PrEP. Prevention doesn't have to wait till after an exposure. With HIV PrEP, we can offer people prevention prior to exposure. And HIV PrEP has really transformed the way we think about HIV prevention. And so really making sure that we offer patients a medication they can take either daily. For men, they can take it on demand. And we now have two different forms of injectable PrEP that are great for all populations that can allow us to prevent HIV. For those who haven't seen it, on World AIDS Day, many cities across the United States released their 2023 HIV numbers, or 2024 HIV numbers. And I've seen at least both New York City and Chicago demonstrated high new rates of HIV acquisition, really highlighting the importance of making sure we offer HIV PrEP to our patients. And that brings us to our topic for today, the newest addition to our medication prophylaxis toolbox, doxycycline post-exposure prophylaxis. Unlike HIV PrEP, which is taken daily, DoxyPEP is taken after a potential exposure with the goal of preventing bacterial STIs. And today we'll cover the benefits, risks, and implementation of DoxyPEP. And like always with my talks, I like to ground these discussions with a case. And this is a real case who came through our sexual health clinic about a year ago. This is Marcus. He's a 29-year-old male in New York City. He's been taking HIV PrEP for HIV prevention for years. He's sexually active with men, has 4 partners since his last visit, but no condom usage. And he comes at the clinic complaining of 2 days of green penile discharge. So we did our routine sexual health clinic workup, which includes HIV testing with a 4th-generation HIV antibody antigen test. Syphilis testing, we use the traditional algorithms, so starting with an RPR, and 3-site gonorrhea and chlamydia testing. And per the STI treatment guidelines, we treated him empirically with ceftriaxone and doxycycline. Marcus is already using many of the prevention tools we talked about. For primary prevention, he's been vaccinated against HPV, hepatitis A, B, meningococcal disease, and Mpox. He takes oral HIV PrEP every day, as is his preference. And he does routine screening every 3 months. He also knows to come in for syndromic testing and treatment as he did today, and is coming before for presumptive treatment after a prior exposure. One area where he has been reluctant is in providing expedited partner therapy or partner treatment to his partners. So his labs were negative for HIV, but positive for gonorrhea in his urine, pharynx, and rectum. His RPR was 1 to 128, up from 1 to 4 just 2 months ago. And so we diagnosed him with gonorrhea and early latent syphilis. You may remember he was treated with ceftriaxone and doxycycline. And so because this was part of the ongoing DPG shortage, we just called him and extended his doxycycline to be a 14-day course due to the ongoing shortage. However, Marcus returned 6 weeks later saying, "I got totally better, but now it hurts again when I pee." He told us he'd had 7 condomless partners since his last visit. He's sure that his regular partners got treated for gonorrhea and syphilis. And so he's coming back in today complaining of recurrent dysuria and a small amount of discharge. So we again repeated our routine testing, and we again treated him empirically with ceftriaxone and doxycycline. His repeat labs came back negative for HIV, and encouragingly, his syphilis titer came down very quickly from 1 to 128 to 1 to 32, showing an appropriate treatment response, even though we used doxycycline and not BPG. At the same time, he once again tested positive for gonorrhea, and this time in his urine and pharynx, and he now has a new diagnosis of rectal chlamydia. So we called Marcus to give him his results, and he was pretty upset. "This is really frustrating. Is there anything I can do to stop getting sexually transmitted infections?" And again, this is where DoxyPEP comes into play. What he's asking about is a form of primary prevention, preventing acquiring STIs in the first place. And DoxyPEP has now joined HIV PEP and PrEP in our STI medication arsenal. To get us all on the same page, I like to start with what am I talking about when I say DoxyPEP. Operationally, this means taking 200 milligrams of doxycycline by mouth, ideally within 24 hours, but up to 72 hours after a condomless sexual encounter at any anatomic site. When we think about DoxyPEP, there are really 3 key questions we need to answer. First are the benefits. Does it work? The second are the risks. Does it cause harm either to the patient or to the larger community? And finally, implementation. How can we safely, effectively, and equitably integrate this into practice? And we'll go through each of these in turn. So it all starts with the most fundamental question: does DoxyPEP work to prevent STIs? So our next poll, approximately how effective is DoxyPEP against chlamydia and syphilis? Please choose the closest answer. All right, we have a wide range of answers, but about 3/4 of people chose 80%, which is the correct answer. So that's really awesome that we already recognize just how effective this is against chlamydia and syphilis. All right, so we now have multiple published randomized controlled trials about DoxyPEP to prevent sexually transmitted infections. We have the IPERGAY trial, the DoxyPEP trial, the DoxyVAP trial, and the DPEP trial. And from these 4 trials, we know very clearly that DoxyPEP is safe and well tolerated. DoxyPEP prevents STIs in men who have sex with men and transgender women. Overall, it's about 81% or so effective against chlamydia and syphilis in the clinical trials. and around 51 or 53% effective against gonorrhea in 2 of the 3 clinical trials. The Iceberg trial did not show a reduction in gonorrhea. We also know that DoxyPEP did not prevent STIs in women in the DPEP study, which was done in Kenya. And there's lots more to come. There's some ongoing studies that are comparing DoxyPEP to DoxyPrep, taking it prior to exposures. We also have the Foxy Doxy study that's re-looking at DoxyPEP in people with vaginas. So let's start with the benefits in the real world. Does DoxyPEP prevent STIs in the real world and not just in clinical trials? We know that what happens in the clinical trial environment does not always translate perfectly into everyday clinical practice. And the answer in this case is absolutely. Across multiple US cities, we're seeing consistent reduction in bacterial STIs, especially in chlamydia and syphilis. In San Francisco clinics, DoxyPEP use cut both infections, chlamydia and syphilis, in roughly in half. At Kaiser Permanente, chlamydia positivity dropped from almost 10% to 2%, and syphilis from nearly 2% to 0.3%. A 96-week follow-up in San Francisco confirmed that those reductions were sustained for chlamydia and syphilis, though gonorrhea initially decreased, but then rose by the end of the study. Chicago's STI clinics reported a 77% overall reduction in bacterial STIs among young men who have sex with men, no new cases of syphilis. In Philadelphia, public clinic cohort showed almost 40% fewer overall STIs, and those reductions were confirmed when people crossed over into DoxyPEP use. At our clinic here in New York City at Columbia, the comprehensive health program, our early adopters had their STI positivity cut in half, with the biggest effect seen for chlamydia. In Boston, we saw meaningful reductions in chlamydia and syphilis, and even some spillover reductions in STIs among people not on DoxyPEP. So the real-world data align closely with what we've seen in the clinical trials. DoxyPEP works outside the research settings and is highly effective for chlamydia and syphilis, and less effective for gonorrhea. One thing I do want to highlight is that in the Kenya DPEP trial, doxycycline did not reduce STI incidence among young women, but they did some qualitative work to suggest why. They interviewed nearly 70 participants, as well as doing some hair sample analysis, and they suspect that adherence was a core issue. The data that they have suggests that adherence challenges, not drug ineffectiveness, explains the null results, and that's why a second trial in the United States is currently ongoing. We do have a small amount of real-world data on females. In the US, 4 sexual health clinics reported their early experience with DoxyPEP among individuals assigned in females. And out of more than 5,700 patients on DoxyPEP, only 35 were females, with a median age of 29. Nearly all report condomless sex with cisgender men, and many had additional vulnerabilities such as sex work or chemsex. The median duration of DoxyPEP use was about 8 months, typically with 2 to 3 doses per month. And when you look at the STI outcomes prior to DoxyPEP, 46% had greater than or 1 STI, and after DoxyPEP, only 20% had greater than or equal to 1 STI, with gonorrhea and Mycoplasma genitalium being the most common and the least likely to be protected by DoxyPEP anyway. No pregnancies were observed, although pregnancy screening was inconsistent, and it really highlights the urgent need for efficacy data in this population, since it's already being used in the real world. So I think it's clear that DoxyPEP is very effective for certain populations, but that's really only half the equation. The other half is, what do we know about the risks of DoxyPEP? And so what's your biggest concern about providing DoxyPEP to patients? Is that it doesn't work or won't work long-term? Risk compensation? Worried about changing the presentation of STIs? Worried about generating resistance to STIs? Worried about generating resistance to commensal organisms? Or something else that please put in the chat for us. All right, looks like the biggest concern is about generating resistance to STIs. Some people are worried about generating resistance to commensal organisms, and then risk compensation is up there as well. All right, so let's talk about some of these things that we're worried about today. So I want to start with the concerns about DoxyPEP, and I think this article is really interesting. It was released in 2018 around the time of the Hypergay trial, which was the first DoxyPEP trial that I had in my table earlier, and was written by Jean-Michel Molina, the lead of that trial, who urged us to take his own trial results with caution, saying that previous trials of antibiotic prophylaxis have shown only limited and transient benefits. Risk compensation might offset early benefits. Antibiotic prophylaxis might change the presentation of STIs. The impact of doxycycline use on the microbiome remains to be assessed. It might select for antibiotic resistance outside the field of STIs. And the greatest fear is by far the risk of selection of doxy resistance to chlamydia and syphilis. So the first is the issue of how DoxyPEP will impact sexual behavior, which gets at this idea of risk compensation, which some people in our survey were concerned about. I want to be clear that we shouldn't be concerned about people having more sex. In some ways, that's what we want. We want patients to be comfortable enough to have as much sex as they want to be having. But one way that DoxyPEP differs from HIV PrEP is that HIV PrEP is almost 100% effective, while DoxyPEP is less so, particularly for gonorrhea. So there is the potential for risk compensation to ultimately result in more STIs, negating the benefits of DoxyPEP. However, with that said, it's not what we're seeing. In both the DoxyPEP and DoxyVac studies, DoxyPEP did not appreciably change sexual behavior. The second clinical concern is that antibiotics may change the presentation or diagnosis of STIs. So far, this data has really been limited, but there is notable concern about the impact on syphilis serological testing, including partial treatment, delayed diagnosis, and false negatives. These two recent case reports highlight one of these potential unintended consequences, its impact on syphilis diagnostics. The first describes a young man using weekly doxycycline who went on to develop neurosyphilis. His initial serologies were equivocal or negative, possibly because of intermittent doxycycline blurred his early antibody response, delaying diagnosis. The second report describes a 24-year-old person on PrEP using intermittent doxycycline with ongoing discordant syphilis results. Eventually, his treponema antibody even reverted to negative after treatment, a fairly unusual phenomenon. The key takeaway is that doxy prophylaxis may mask or delay syphilis serologies. As more patients use DoxyPEP, we need to keep syphilis on our differential, especially when people have clinical signs and symptoms, even if the test results don't fit the typical pattern. And those clinical concerns are relatively minor compared to the concern about antimicrobial resistance. And that was reflected in our survey results today. The majority of people are really concerned about resistance to either STIs or commensal organisms. And that's one of the biggest reasons stopping providers from using DoxyPEP. And those concerns are not just theoretical. We know that DoxyPEP will lead to an increase in antibiotic use, and DoxyPEP will increase doxy usage even when accounting for the reduction in antibiotics used. And so this will result in more doxycycline being used. So let's start by talking about the potential for antimicrobial resistance in STIs. I'd like to start off easy, and that is with chlamydia and syphilis, where we believe the risk is relatively low. For chlamydia, no clinical resistance to tetracyclines in chlamydia trachomatis have been seen, and we've been using doxy for treatment for years. There is some mild concern because tetracycline resistance has been seen in chlamydia suis, which is in pigs, but not in humans. For syphilis, there's also been no clinical resistance to tetracycline seen. And this is really important right now, as many of us are having to use doxycycline for syphilis due to the second ongoing DPG shortage in just the past 3 years. The concern about resistance in syphilis mainly stems not from doxy, but from the widespread macrolide resistance that was seen with a single point mutation in syphilis. This mutation was so significant and widespread that the CDC now recommends against using macrolides for syphilis because greater than 98%, 99% are now considered resistance. There was a recent 2025 study that tried to directly test the possibility of doxycycline generating doxy resistance in syphilis, and they exposed strains of syphilis both intermittently and continuously to low-dose doxy over several months, and tracked any changes in the minimal inhibitory concentration. The result was very reassuring. There was no evidence of resistance, minimal inhibitory concentration stayed stable, and no key mutations appeared that could cause tetracycline resistance in syphilis. And so while we still need real-world surveillance, this study strongly supports that DoxyPEP is not driving syphilis resistance in the lab. Next up is Mycoplasma genitalium, now one of the most common STIs we get consulted on at the PTC, rapidly overtaking even syphilis. Back in 2025, we called it an emerging STI, but by 2021, it had its own section in the CDC guidelines. And I know that Jacob will talk about it later today, so I won't go into a lot of detail right now. What's important for us to know for this talk is that we have limited antimicrobial resources for Mycoplasma genitalium. It's intrinsically resistant to cell wall and folic acid inhibitors. It already has high resistance rates to protein synthesis inhibitors and high resistance rates to nucleic acid synthesis inhibitors like quinolones. The current treatment guidelines is based on this study out of Australia that suggests that doxy followed by moxy or azithro has greater than 90% efficacy. But the theory is here what we see on the right. The doxycycline reduces the bacterial load, and then the second agent helps clear the infection. However, it's unclear what the effects of increasing doxy resistance will do in this case. If it no longer lowers the bacterial load, we'll be able to clear the infection. And that's why it matters here, because could widespread DoxyPEP usage make it more challenging to treat MGen? And we don't know the answer to that yet. Finally, the biggest concern isn't resistance. The biggest concern is resistance in gonorrhea. The issue isn't that we use doxycycline to treat it. We don't, and we haven't for many years. But if resistance rises, DoxyPEP may be less effective. Even more worrying is the potential for cross-resistance to spread to other antibiotics, including ceftriaxone, our primary reliable option. This modeling study done by Mortimer and Grad showed that chromosomally mediated tetracycline resistance is especially linked with co-resistance to other classes. And the key takeaway is simple. The key takeaway is simple. As DoxyPEP rolls out, we really need ongoing surveillance, including that for gonorrhea, to detect and prevent the spread of cross-resistance. So those are our STI-specific concerns, but it doesn't stop there. We also need to think about commensal bacteria, the organisms that live in our gut, skin, and oropharynx. They matter for two reasons. First, they act as reservoirs, passing resistance genes to other pathogens. And second, because they can cause infections themselves, things like Staph aureus or group A strep, meaning resistance in commensals has direct clinical consequences for our patients as well. This was a systematic review looking at the impact of tetracyclines on antimicrobial resistance of normal flora. And they actually found only 7 articles fulfilling their inclusion criteria, most with a high risk of bias, highlighting how limited our data is on resistance and persistent doxy exposure. What they found is that limited data from small prospective studies suggest that oral tetracyclines for 2 to 18 weeks increase resistance in subgingival, gastrointestinal, and upper respiratory tract flora. But this really highlights just how little data we had before rolling out DoxyPEP widespread. And we're now starting to gain more real-world evidence of what's going on. When we focus on just STIs, gonorrhea is the major concern, as I talked about earlier. In King County, resistance to tetracyclines in gonorrhea jumped from 27% to 70%, with high-level resistance rising to 65% among users, really suggesting that DoxyPEP is accelerating gonorrhea resistance to tetracyclines. The French DoxyVac study confirmed that there was more tetracycline-resistant gonorrhea in the DoxyPEP arm, and the US DoxyPEP study had limited culture data, but didn't show significant gonorrhea resistance, really highlighting the importance of ongoing surveillance. Importantly, and maybe most importantly, a post hoc analysis found no evidence that DoxyPEP is driving ceftriaxone resistance. So the takeaway here is that DoxyPEP may be accelerating tetracycline resistance in gonorrhea, although ceftriaxone remains effective, which is probably the most important takeaway here. Beyond STIs, DoxyPEP also selects for resistance in commensals and bystander bacteria. We know oral tetracyclines can drive resistance in the gut, mouth, and respiratory tract flora, and nearly half of commensal Neisseria isolates, so not Neisseria gonorrhea, but commensal Neisseria isolates, were resistant in one study, and that rate was higher in recent doxycycline users. Metagenomic work showed tetracycline resistance genes rising in the gut, particularly in frequent DoxyPEP users, though the overall microbiome didn't change substantially. And Staph aureus resistance is concerning since it often co-selects for, and tetracycline resistance in Staph aureus is also concerning because it also co-selects for other resistance mechanisms like Bactrim and clindamycin. Both the US DoxyPEP and King County studies confirmed more tetracycline-resistant Staph aureus among users. Finally, the Kings County data set also flagged group A strep with tetracycline resistance in DoxyPEP users. And that's important because commensals aren't just bystanders. They can actually become invasive pathogens themselves. And so the bottom line is that DoxyPEP does result in more increased resistance amongst commensal organisms. And so it's something we need to be aware of, particularly if we're prescribing antibiotics to a person taking DoxyPEP for a skin and soft tissue infection, for strep throat, for other things. We may want to avoid using tetracyclines and look at other classes of antibiotics. So to summarize the resistance concerns, in gonorrhea, we saw the rapid rise in tetracycline resistance, no evidence of co-resistance with ceftriaxone, which is fantastic, and surveillance is critical. What we expect is that DoxyPEP will not be effective against gonorrhea long-term, given this rise in tetracycline resistance. But as long as we don't start seeing co-resistance with ceftriaxone, it's very reassuring. Commensals as reservoirs, resistance is emerging in commensal Neisseria, gut flora, Staph aureus, and group A strep. These organisms can both spread resistance genes and cause their own infections. And we need to think about this when providing empiric antibiotics. This is not a reason not to use DoxyPEP, but it's a reason to think about what you're going to give people if they develop other types of infections. In terms of co-selection risk, tetracycline resistance in Staph aureus is linked with resistance to trimethoprim sulfamethoxazole and clindamycin. And so DoxyPEP may be indirectly driving multi-drug resistance, and is something we need to focus on studying. In terms of counseling our patients on DoxyPEP risks, I like to break into 3 categories. We have the well-known side effects, gastrointestinal distress, photosensitivity, and piloesophagitis. We have a growing understanding that we don't see resistance with chlamydia and syphilis. We're seeing some decreased colonization in Staph aureus and resistance emerging in gonorrhea and commensals like Staph aureus. We really don't know the impact of Mycoplasma genitalium on the microbiome, how it impacts STI diagnostics and presentation, as well as we really don't know yet the potential cross-resistance with other antibiotics. So we've gone through the benefits. We know that DoxyPEP can help our patients. We've gone through the risks, so we know what to look out for, and we know how to counsel our patients. So how do we start DoxyPEP in our practice? Well, the 2024 CDC guidelines have very clear recommendations. They say that providers should counsel all gay, bisexual, and other men who have sex with men and transgender women with a history of at least one bacterial sexually transmitted infection, specifically syphilis, chlamydia, or gonorrhea, during the past 12 months about the benefits and harm of using doxycycline. And the ongoing need for DoxyPEP should be assessed every 3 to 6 months. So they're giving us a specific population with a specific vulnerability, having an STI in the prior 12 months, who we should be offering DoxyPEP to. And then they're saying we should be reassessing their need every 3 to 6 months. There are no recommendations made about the use of DoxyPEP for cisgender women, cisgender heterosexual men, transgender men, and other queer and non-binary persons due to the lack of evidence at this time. So in terms of implementation, we need to think of it as part of the broader STI prevention landscape. This slide highlights our secondary prevention again, making sure we do routine screening for HIV, gonorrhea, chlamydia testing, including extragenital testing, syphilis testing, hepatitis testing, assessing individuals' vaccination status, and counseling them on prevention strategies, including the benefits and risks of DoxyPEP and drug-drug interactions. We did our counseling slide a few minutes ago, and this is the counseling slide. I also always recommend patient decision aids. These can be incredibly helpful in clinical practice to make complex information accessible, support shared decision-making with patients, and really empower patients to take a more active role in their care. Our team here at Columbia piloted this patient decision aid, and with 30 patients, and we found that it increased familiarity with DoxyPEP, comfort with DoxyPEP, and knowledge about DoxyPEP, and they rated it highly acceptable, appropriate, and feasible. It's available online, as well as this one from the California Department of Health, that are both really great ways to talk to your patients and to use with your patients when discussing DoxyPEP. How should you practically prescribe DoxyPEP? Well, since I don't have screenshots of everyone EMR, I have an old school prescription pad. And I feel a little old because I suspect many people on this call have never actually written out a prescription like this. The first is to start with drug name. You can use either doxycyclate or doxymonohydrate. You can also use either immediate or delayed release. The immediate release formulations are more widely available and usually cost less than the delayed release formulation. And hyclate is usually cheaper while monohydrate has less GI discomfort. And so frequently this is dictated by insurance, but know that whichever one you use is perfectly acceptable. The second thing is to provide detailed instructions. When we first started prescribing DoxyPEP, we didn't always include this level of detail, but it's amazing how often patients go back to the instructions to remind themselves how to take their medication, which makes clear written instructions essential. For example, 200 milligrams by mouth within 72 hours of condomless sex, no more than one dose in 24 hours, take with water, and remain upright for 30 minutes. One thing I do remind people of is we need to be mindful of privacy. Some patients may not want DoxyPEP written on the bottle, and in those cases, consider giving them written instructions in clinic, or even a sticker they can place on the bottom themselves or keep at home, so they still have a discrete but reliable reference for how to take this medication. Finally, and most complicated and probably most controversial is how many pills to give. In the studies, 25% of patients use 10 doses per month or more. And I think that if you're aiming to see patients quarterly, the best approach is to aim for a 3-month supply based on their individual expected activity. For many patients, 60 tabs or 30 events, 10 a month, is a reasonable number, but you could go higher or lower depending on an individual's expected sexual activity. I do think that this is one thing that needs to be an individualized process that I recognize is challenging to operationalize. And then this is what my order looks like in our EMR here, where I have my instructions in the patient signature, and I'm able to put everything in there and use it each time. How do we follow patients on DoxyPEP? So as we saw in the trials, while DoxyPEP is effective, it is not 100% protective, and again, less so these days against gonorrhea. Untreated STIs under ongoing antibiotic pressure are likely to contribute to resistance. And so for that reason, we recommend continuing to follow the existing CDC STI and PrEP guidelines, which mean quarterly, every 3 to 6 month STI testing for individuals on DoxyPEP. So in practice, patients should be seen every 3 to 6 months. At those visits, we can repeat HIV and STI screening. We can assess for side effects. We can repeat counseling, reassess the need for prevention modalities, and then re-prescribe as appropriate. When patients on DoxyPEP are diagnosed with an STI, the approach is pretty straightforward. We continue to treat them according to the 2021 CDC STI treatment guidelines. One nuance is that because patients are already taking intermittent doxycycline, it's worth pausing and thinking about whether we need to treat people after just an exposure. Instead of empiric treatment, if they're taking DoxyPEP as appropriate and they took it after that sexual encounter, we should think about bringing them in for an in-person exam and testing and deferring empiric treatment for exposure to really get the benefits of DoxyPEP. These are some of the most common clinical conundrums we get asked about DoxyPEP. First is, what about if a patient comes back positive for chlamydia after they've been taking DoxyPEP? The answer is we continue to treat them by the 2021 STI treatment guidelines with doxycycline 100 milligrams by mouth twice daily for 7 days, and there's no change in management. My patient is taking DoxyPEP incorrectly. That happens very frequently. Think about bringing them back in to repeat counseling and provide documents like those patient decision aids to assist with taking it properly, because it can be challenging. There are not many things that we take in an on-demand fashion like this. And so making sure they understand how to take it is important. We should not be cutting people off from DoxyPEP just because we're unable to understand how to take it correctly. My patient's partner was diagnosed with an STI. Again, we want to first assess if our patient took DoxyPEP appropriately after every recent encounter with that partner. And if so, consider in-person assessment and testing as opposed to empiric treatment. All right, going back to our patient, Marcus, he had had gonorrhea twice recently, but he also had syphilis and rectal chlamydia. Would you offer him DoxyPEP? And almost everybody said yes, which I'm very happy to hear. I always worry when I go through the risks of DoxyPEP, I'm scaring people off, but I think it's an incredible intervention for people who do have STIs. So Marcus decides to start DoxyPEP. He does come back to clinic 4 weeks later, complaining of recurrent dysuria and green penile discharge. We repeated his labs, but because it's his third visit in a short period of time, we actually did a gonorrhea culture as well. And he was treated with an alternative regimen, gemfibrozil, since he'd gotten ceftriaxone twice in the past 6 weeks. His labs again returned positive for urine and pharyngeal gonorrhea. His rectal was negative. His RPR continued to decline. His HIV testing was negative. And his gonorrhea culture actually came back with a little bit of an elevated resistance to ciprofloxacin and resistance to tetracycline, but fully sensitive to ceftriaxone, really supporting that this is reinfection and not treatment failure, given the excellent MIC to cephalosporin or ceftriaxone in particular. So will it work for prophylaxis? This is one of the big worries we have because globally, tetracycline resistance in gonorrhea is rising. This systematic review looked at over 80,000 gonorrhea isolates worldwide. Overall, tetracycline resistance was about 54%, but much higher in East Asia and Africa, over 80%. And while lower in North America, this data was older data and had quadrupled since 2009. And we saw in the Kings County data, especially where DoxyPEP is rolled out early, we see that increase rapidly. The WHO surveillance program probably gives us the clearest global picture of tetracycline resistance in gonorrhea. Between 2021 and 2024, nearly 3,000 isolates were collected from 8 countries. Over 90% were resistant using standard clinical thresholds. And even when applying higher cutoffs more relevant to prophylaxis, 3/4 were resistant. The key point here is that tetracycline resistance in gonorrhea is already high globally. And that means the effectiveness of DoxyPEP for gonorrhea prevention is likely to be limited. And so when we're counseling our patients on the benefits of DoxyPEP, we really should be focusing on chlamydia and syphilis and just setting expectations that they may still acquire gonorrhea, and they should not consider that failure of DoxyPEP if they do. So what else can you offer him? So if DoxyPEP is unlikely to work, is there anything else we can do? And I'm getting a lot of questions about vaccination. The UK recently became the first country to launch a national gonorrhea vaccine program. And NHS messaging has described this as a major step forward against rising gonorrhea rates and antimicrobial resistance. They've highlighted that this vaccine is already used to protect against meningococcal group B and said that it's proven to be effective against gonorrhea, which is not exactly true. So let's talk about this. And before we look at the evidence about whether this vaccine even works, why would a meningococcal B vaccine have any impact on gonorrhea in the first place? Well, the MenB4C vaccine wasn't designed for gonorrhea. However, when you look at the genomes of Neisseria meningitidis and Neisseria gonorrhea, many of these outer membrane proteins overlap between the two species. And because this vaccine is targeted to the outer membrane proteins, this overlap helps explain why antibodies generated by MenB vaccine may also recognize gonorrhea and provide partial protection. And it's also important to know that we don't need complete protection for a gonorrhea vaccine to be really meaningful. Modeling studies suggest that even moderately effective vaccine could have a major population level impact. For example, with just 30% coverage among men who have sex with men, a vaccine with 50% efficacy of gonorrhea, a vaccine with 100% efficacy could reduce gonorrhea by 94% within 2 years. And even with only 50% efficacy, gonorrhea incidence could still fall by 62% within 2 years. Importantly, elimination of gonorrhea is possible within 8 years if vaccine efficacy is at least 50%. So even a partially effective vaccine could be transformative at the population level. And there are several observational studies that suggest that MenB does provide modest protection against gonorrhea, generally in the range of 40 to 50%. However, these are only observational studies, which present significant limitations. The one randomized control trial we have is the DoxyVax study. This study looked at DoxyPEP, but had actually 4 arms: DoxyPEP alone, MenB vaccine, DoxyPEP and MenB vaccine, and then nothing. So look at 4 different arms and try to evaluate whether Men-B would be successful for gonorrhea prevention. And their study did not show the efficacy of forced Men-B vaccine for gonorrhea. So a recent meta-analysis with pooled results across studies found that Men-B vaccination was associated with a 32 to 40% reduction of gonorrhea. However, the key detail here is that most of the evidence comes from observational studies. The only randomized controlled trial is this top one up here that has the blue arrow, which did not demonstrate significant protection because it crossed 0. Although when you look at the confidence interval, it's likely it provided some protection, but well below the 40% needed to be, or 50% needed to really be meaningful. And that's why you don't see the Men-B vaccine recommended here in the US immunization schedule for gonorrhea prevention, but it does recommend particularly men who have sex with men Hep A and B, HPV, men ACYW, and Mpox. And so vaccination is a critical piece of prevention, but maybe not yet for gonorrhea. So would you offer Marcus Men-B vaccination? Interesting. About 80% of people would offer Men-B vaccination to Marcus. Fascinating. So we did not offer Marcus Men-B vaccine. It's quite expensive, and given the limited data on its efficacy, we are not routinely doing that in our sexual health clinic, although I imagine there are some that are doing that. In summary for today, we're in an era of STI prevention choice, and patients should be aware of their options. Real world data on DoxyPEP really supports the clinical trials, confirming its effectiveness for syphilis and chlamydia, but mixed for gonorrhea. It clearly works to prevent syphilis and chlamydia in populations with or without HIV. It did not work in females in the DPEP study. It reduces STIs, but does drive tetracycline resistance in gonorrhea and commensals, with risk of co-selection for multi-drug resistance. And there remain unknowns about the overall impacts, risk, and unintended consequences of DoxyPEP that potential users should be aware of before starting. For CMNB, observational studies offered modest protection. The one randomized controlled trial did not show a significant reduction in gonorrhea incidence, and flexibility will be the key. Management will change as we learn more. Surveillance and research is what's really important to understand the long-term risks, benefits, and optimize prevention combinations. For additional information, as a reminder, we have the National STD curriculum and the National Network of PTC Clinical Consultation warm line that's available. And with that, I will stop and take any questions.
All right, thank you so much, Dr. Zucker, for that wonderful presentation. We do have a few questions here in the Q&A. So this question asks, is there any research on using oral cefixime like DoxyPEP, but to better help cover gonorrhea?
There's not currently any data on using cefixime for prevention of gonorrhea. One thing I will say is that we know that gonorrhea develops resistance to cefixime relatively quickly. It was in prior iterations of the guidelines, and very quickly we saw rises in gonorrhea resistance to cefixime. And so it actually was removed for one cycle of the guidelines and then reintroduced at a higher dose. The other thing I'll say is there's some recent WHO data that I didn't present today that really looked at cephalosporin resistance worldwide to gonorrhea and found an alarming amount of cephalosporin resistance, particularly to cefixime. And so I don't think it's something that's ready for prime time. And I think we really would want to preserve cephalosporins because we do know that cephalosporins can drive, cefixime can drive ceftriaxone resistance. And so it may be something we want to avoid so that we continue to maintain ceftriaxone available for gonorrhea.
Great. How would you respond to concerns of doxycycline being used for other illness states instead of how it was prescribed for DoxyPEP?
Yeah, that happens frequently. We know that if we give people an antibiotic, they are going to take it for other things. The best I can offer in those situations is to try to provide counseling to patients on why and when to use DoxyPEP as intended, and the reasons for not using it when not intended. For example, if they use additional doses for a viral illness, they're, risking additional side effects without any potential for benefit. Also, going to your doctor in those circumstances and being checked out and evaluated will allow them to figure out if something more serious or more significant is wrong, as opposed to just taking an antibiotic for no reason.
Could you provide guidance on monitoring patients with a recent syphilis infection who are currently taking DoxyPEP? Specifically, how do you recommend syphilis monitoring in this context?
So I have not changed my practice in the area of DoxyPEP. We've not seen enough data that suggests we need to. So I continue to monitor patients as per the STI treatment guidelines with repeat syphilis testing as recommended there. So whether that's every 6 months or every 3 months, depending on their living with or without HIV, have not changed the way I practice, and it's continued to work for now.
How do you counsel on the continued use of condoms while discussing DoxyPEP?
I think that's a great question. I remind people that condoms are our most effective multi-purpose prevention technology. They prevent pregnancy, they protect bacterial STIs. They prevent viral STIs, which are not prevented by medication prophylaxis. They can prevent gonorrhea, which is not particularly well taken by medication prophylaxis. And so I try to encourage people to use as many of these methods of primary and secondary prevention as possible. With that said, we also want to avoid being judgmental. When we're judgmental and when shame people for not using condoms, all we really do is drive them away from care. What we want to do is embrace them in care, get them to use as many STI prevention modalities as they're comfortable with, make sure that they're all available to them, and let them decide what's best for their personal lifestyle.
Great. Can you talk more about the MenB vaccine, the general benefits, and it not being worth it due to the cost? Is that the only barrier for use?
There are recommendations on when we should be giving people MenB vaccine, and I didn't go into them today, but people who are going to universities and other things, we should, at least currently in my practice, we're using MenB as it's recommended by the CDC currently. We've not expanded that to include gonorrhea prevention because there isn't evidence that it works, and we try to be evidence-based as much as we can.
If a patient is taking DoxyPEP, would it be beneficial to reverse screen for syphilis at labs? Would that possibly detect cases that would be a false negative?
I don't think we know because, again, even the direct treponema antibody testing is still antibody testing. We don't know the impact of DoxyPEP on that. One other thing that's a little bit challenging is that those tests are frequently positive for light. And so people who have ever had syphilis, like many of our patients in sexual health programs, will often test positive on the antibody. And it's really the RPR, the quantitative non-treponemal test that we rely on to help us assess for reinfection.
In your experience, do you find that patients share DoxyPEP with their partners? And do you think it will become an EPT or expedited partner therapy medication?
Yes, and I hope not. One of the benefits of people coming into clinic is that we can provide them more than just EPT. EPT is always our second option. Our first option is partner services. We want to bring partners into clinic so that we can A, offer them testing, and B, offer them this entire suite of STI prevention services, not just one or two services that we're able to provide them through expedited partner therapy. And so whenever I see patients who are telling me that they're sharing Doxy with their partners, I try to encourage them to bring their partners into clinic so that we can offer their partners a range of services and they're not just left using just the one.
Okay. Is there a study going on to see if they can vaccinate college students with the MenB vaccine and have lower rates of gonorrhea?
Not a clinical trial, but that's actually what a lot of those observational studies looked at. They looked at young people who had gotten MenB vaccine for the standard indication and saw whether or not they saw lower gonorrhea rates in those groups.
Given more frequent exposure to ceftriaxone for both empiric and directed therapy for gonorrhea, is there any impact on the emergence of ESBL producing uropathogens?
I'm trying to think of the data I know of. I don't know of anyone that I'm aware of. Yeah. So I don't know I don't know. I think the answer is we don't know. I don't think we've studied that particular question enough. And I think it's an interesting question, but I don't think we've studied enough. And can't think of a study off the top of my head that specifically looked at that. DoxyVac did look a little bit at ESPLs, but I think it was in the gut. and they did not see an increase in ESBLs in the gut in a small percentage of patients. I know there are a couple of ongoing funded NIH studies that are trying to look more at resistance in DoxyPEP, just so we can better understand the impact of it.
Has anyone looked at STI infections in patients with ongoing doxy for acne?
We talk about that all the time, and there are not a lot of long studies about that. The problem with the acne dosing, it is a lower dose. We use 200 milligrams for DoxyPEP, and we use 50 milligrams for acne. When I have patients who've been taking DoxyPEP for acne and want to get on DoxyPEP, I just recommend they skip their 50 milligram dose that day and take the 200 milligrams instead. But I can't think of any particular study that's looked at studying the 50 milligram dose.
This is a question from earlier about the prozone effect. There was just a clarification about, did you mean to say false negative for the prozone effect when it comes to syphilis?
Yes.
Okay, thank you. Yeah, just wanted to get that on the record. Um, let's see here. Would you say, is the DoxyPEP regimen of 200 milligrams per 24 hours the same regardless of sexual encounters?
Yes.
And how often should patients who take DoxyPEP be tested for STIs?
Um, so as we mentioned before, they should follow the current STI treatment guidelines, which would recommend every 3 to 6 months.
Okay. If anyone else has questions, please pop them in the Q&A section. As questions come up later on, we can also send them to Dr. Zucker. And yes, slides are going to be shared with registrants after this program. Okay, we do have another question. Can you split the dose of doxycycline twice a day for PEP?
I don't think we know. Let me forget. We don't know the answer to that question. Thinking about the PK, I would say maybe, but I would not recommend doing it. I think we run the risks of it not working, and we just don't have enough data to support it.
I know you had just recently talked about this, but do you know of any newer research around the MenV vaccination to help prevent gonorrhea? Like any newer studies that are like ongoing or happening currently?
There are a couple of ongoing studies that are looking at that question still. The DoxyVac one was the first one to be completed. And so there are studies that are almost completed.
Do you have any recommendations for people who have significant GI side effects for taking doxycycline?
I think it's a challenge, other than taking it with food, making sure you stay upright for 30 minutes after taking it are really the two I can do. But we have had people who had to stop DoxyPEP because they simply couldn't tolerate the GI side effects. And in those cases, we go back to what we did 2 years ago before DoxyPEP of routine testing and other prevention modalities from our options.
That's great. So there's a question here. Where can I find the STI patient counseling guides that Dr. Zucker mentioned during this
We can
talk?
post the links.
Yes, yeah. So they have been dropped in the chat, but we will send them out like via email. They're on our website as well. The DoxyPEP patient decision aid that was that Dr. Zucker went over during his presentation. Okay, I don't see any other questions for right now. Yes, of course. So we will take just a short break.